Should I give her a call?
Yeah, I think you can give her a call. Maybe Sandhya can join. We will start with Dr. Dhanashree ma'am's talk. Meantime, you can call up Sandhya maybe.
Mhm. Yeah, I think the meeting is started.
You are live now, ma'am.
Hello, everyone. We welcome you to our first Retina update of Women in Retina under WAS. And this is our very first step to start off something which can become really big, as in connecting all the female retina surgeons all over the country. And we can help each other know much more than we already know, help each other learn much more. And going forward, this the first update is on a very relevant topic nowadays, which is Octa. And I want to welcome our chairpersons. Dr. Madhu is not here. She'll be joining soon. Dr. Karobi is here. Dr. Karobi is a very senior retina specialist from Bombay, and she's associated with Bombay Hospital and Medical Research Institute. Dr. Sandhya will also be joining very soon. We also have a great panel with us. Dr. Praveen Sen is there. She's a very famous ophthalmologist, we all know, a retina specialist, and presently she's working at Dr. Agarwal's Eye Hospital, Chandigarh. Dr. Tinku Bali is here. She's also a retina specialist and is currently associated with Gangaram Hospital, Delhi, and Delhi Eye Center. Dr. Sugneshwari is a senior consultant at Shankara Nethralaya. Dr. Isha Agarwal is a consultant at Shroff Charitable in Retina in New Delhi. Dr. Rajshri Hirawat is a veterina consultant at Kamdar Hospital, Jodhpur, Rajasthan. And Dr. Sampurna Bhattacharya is a consultant of Vitretina at Shankara Nethralaya. So we have a whole lot of female retina specialists from all over the country. And I think with this, we can start with our first talk. Dr. Sugneshwari.
Yeah. Thank you, Dr. Anisha, for the very nice introduction. Now I will request Dr. Dhanashree Ratra, a senior consultant and the deputy director of Bhagwan Shri Bhagwan Mahavir Vitreoretinal Services, Shankar Nethralaya, Chennai, to begin her talk. And she is a very accomplished surgeon, excellent surgeon par excellence, and she's a strong, avid researcher also. And Madam has, to her credit, more than 100 plus publications, and her main area of interest are in diabetic retinopathy, the age-related macular degeneration, and she herself is an expert on intraocular lenses with scleral fixated intraocular lenses. With that, I would request Dr. Dhanashree Radra to help us with the topic on my journey as a women retina specialist. I am sure this will encourage a lot of our other colleagues, junior colleagues, to understand about the retina practice and to understand the life of a senior vitreoretinal surgeon. Over to you, ma'am.
Thank you very much, Sugneshwari, for the kind introduction. And first of all, congratulations to WAS for starting this new chapter. And I wish the women in the retina all the best for a excellent run. So let me share my screen. Okay. So my slides are visible.
Yes.
Okay. So first of all, I would like to thank Dr. Moita Sharma and the Women Ophthalmology Society for this rare honor. It's really a privilege for me to talk to you about my journey as a woman retina surgeon. So let me begin with a statement, or rather, it's a fact that being a woman vitreoretinal surgeon is not just a professional identity. It is a statement of resilience, sacrifice, hard work, and a do or die attitude. And I'm sure all the women retina surgeons that you have today in the webinar and otherwise also when you see them, you will see that each one of them is a testament to these qualities. These are probably the innate qualities which are necessary to become a successful vitreoretinal surgeon. And not only this, along with that, these women retina surgeons, they successfully manage their roles in the family as as wife, daughter, mother, and they achieve excellent work-life balance as well. So it's really I would say, again, I would say it's not just a professional identity, it's really a big honor to become a veterinary, woman veterinary surgeon. However, the journey is not very easy, and I would like to talk to you about my journey. The early years, I give credit to my parents. I am from a middle class Maharashtrian family, and I spent most of my childhood living in villages in Maharashtra. But I studied in a Marathi medium school. But my parents never, let me feel the limitations. They gave me the wings to fly, and they said, "Sky is the only limit for you." And they gave me very strong morals and values, and they taught me to do hard work and sacrifice. The next, I would say, the next turning point in my life came when I joined Mahatma Gandhi Institute of Medical Sciences, Sevagram. This is a very special medical school where, along with medicine, we were also taught the Gandhian principles and the humanitarian principles. I met a lot of my I friends there, and these friends, like these are for life. Even now, we are all together. But apart from the friends, there were a lot of values that I imbibed from these from this medical school. So in during the medical school, we were posted in villages, and we were posted in leprosy colonies, and it was really, I mean, there were no facilities there. There were no, they were not like even the sanitation and all in the villages. There was no facilities, luxuries. There was no Swiggy, Zomato, nothing. We had to manage for ourselves when we were posted in villages. When I was posted in the colonies, leprosy colonies, I have done cataract surgeries for leprosy patients just under a 60-watt bulb. And I have seen people, the suffering, real suffering of these people, but also the will to live with dignity, a very strong will to live with dignity. So it is, at that is the stage where, this was in our young minds, that was, imbibed, that we have to help people alleviate their suffering. The next turning point came when I joined Shankar Netralaya in 1994 for my veterinary fellowship. And at a time when not many women were choosing veterinary surgery as a field of practice because it was a tough field. It required hours of dedication, hard work. I mean, the work would start at 5:30 in the morning and continue till midnight. It was a really hard work with and also challenging work, back-breaking work, really. But the single person who made a difference, a big difference in not only in my life but many other veterinary surgeons was the legendary Dr. S.S. Badrinath. The morals and the values that he taught us. I mean, he not just taught us ophthalmology or VR surgery, he taught us how you can impart medical care empathetically, how you can, be one with the patient, understand the patient suffering, and also at the same time be very ethical. So, what is the Shankar Netralaya brand stands today is for its ethical care at a and also very empathetically it is given. That is why, patients flock to Shankar Netralaya even today. And I am really grateful to Dr. Badrinath for all the opportunities that he gave me. So, and so my journey took me to, he sent me to this Jalna, Ganpati Netralaya Jalna in 1996. Yeah, I had just finished my fellowship, and I started the vitreoretinal department there. And I remember even now, the first patient I operated there was a VIP patient who had an endophthalmitis. And when I finished the surgery and I came out, and somebody told me, there were like 50 people watching your surgery from outside. There was a glass door to the operation theater. So, but luckily, patients did well, and then the department did well. So it started from there. Then 2003, along with my husband, we started the Shankar Netralaya branch in Kolkata. And this was also not an easy task at all. But we stood on the shoulders of two giants, Dr. Badrinath and Dr. Devi Shetty, and managed to, lay the foundation and have now it is a very thriving branch of Shankar Netralaya in Kolkata. Thereafter, I went to Colombo in 2005, where at that time there was only one single veterinary surgeon in the entire country of Sri Lanka. And when I started doing vitreoretinal surgeries, the hospital was not willing to even invest in the instruments. So I rented vitrectomy instruments. I rented the vitrectomy machine and vitrectomy instruments, and I started doing VR surgery in Colombo at that time. So all these experience thereafter, I went to Bangalore and then to China. So all these experiences are very valuable experience. They taught me a lot. Lot about human suffering, about vitreoretinal surgery. And over the past now I have been practicing retina for the past 28 years. I have received a few awards and accolades, and I'm really grateful to God Almighty and my parents, my teachers, my well-wishers for all these awards. I received the best, along with a few best paper awards. I received best researchers from entities like WAS. I received honorary FICO, so I'm really grateful for that. So the journey has not been very easy, but it has been very satisfying. And over the few years, I have had the pleasure to mentor many young VR surgeons, as you can see in so many photos. And some of them are not there in the photos, but they all these ladies, very dynamic young ladies, who are very close to me and my heart. And I hope that in India we now have a big group of women vitreoretinal surgeons who are doing really good work. And I my all the my best wishes to all of them and to this Women in Retina initiative. Thank you so much for your attention. And this is my daughter, and this was at 3 years of age. She was doing my indirect ophthalmoscopy, and now she's doing internship. And I do hope that she takes up retina as her career. Keeping my fingers crossed. So thank you so much. It was very nice talking to you all again, and thank you very much for the opportunity.
Thank you, Dr. Dhanashree ma'am. It was indeed a pleasure watching your journey in Retina, where I'm sure we have shared some years together. So at least 16 years together.
Yes, Sugneshwari is another dynamic VR surgeon from Shankar Nethralaya, and we are proud to have her.
Ma'am, we have many people now. We have so many people now.
Yeah, and our director, Dr. Muna, who
That,
is going to
yes.
come next. Yeah. So we are all following in her path, basically.
Yes. So now I'm going to invite Dr. Muna Bende. She is, to be very precise, we all kind of call her as the queen of retina. The reason being, she is extremely very good, excellent in her skills of getting to a diagnosis. If there is a puzzle, I'm sure Dr. Muna Bende is at it to solve the puzzle. And she is none other than the present director of Sri Bhagwan Mahavir Vitreoretinal Services, Shankar Nethralaya. And madam, to her credit, she has her areas of interest are in age related macular degenerations, and she is a pioneer in all these newer technologies like the Octa, which is there, and imaging and diagnosis. She is really excellent, and she's too good on that. And anything and everything, all of us kind of resort to her, to get the final understanding about if we are lacking in something. And for her, medical retina is something which is almost, I would say, it is like her right hand. She knows it that well, and she's simply superb on that. So today we are going to hear from Dr. Muna Bende, who has almost got around 150 publications. So she is going to be talking to us on the master class on Octa today. Over to Dr. Muna Bende, ma'am, for her to, give the talk on Octa. Ma'am, we are eager to hear from you.
Thank you, Suguneshwari, and thank you, Was, for having me here. She a little overdid the introduction, but it's okay to hear nice things once in a while. And I looked at the program and I found I can't tell you everything about Octa. Definitely not, because we have a good set of cases coming up. But one thing I can say, if at my age I can learn it, everyone in the audience can too. And can you see my slides?
Yes, Dr.
Yes,
Muna.
ma'am.
Yes. So what I'm going to talk to you is maybe where you can apply OCTA and how you can improve your understanding of it. So probably we know that OCT is the most widely used imaging modality in ophthalmology today. And I think most people will do an OCT rather than look at the fundus. But it's invaluable in a retina clinic for diagnosis, follow-up, and assessment of treatment. And Opta is just an extension of OCT that uses motion contrast to visualize blood vessels down to the capillary level. So a few important points. 1 minute, and I think there's a tab which is eating up half my screen. So, yeah. So basically it detects flow in the retinal and choroidal vasculature. And its main importance is it eliminates the need for dye, thereby reducing injection-related complications. And we know that narrow transit window is so crucial when you do your fluorescein angiogram and ICG to catch just that lesion before it starts leaking. And we don't have that in Opta, so you can easily repeat it. You have all the time in the world if you have that time to look for what you think is there. And there's very limited obscuration of retinal and vascular features that can occur with dye leakage. Of course, sometimes fluid and blood can cause obscuration. So basically what happens in Opta is you have a variation in OCT signal, which is caused by moving particles such as RBCs within the vessels. And they use this as the contrasting mechanism for imaging blood flow. And this is basically multiple scans which go along the depth of the retina. And if you look at this picture, it very nicely tells you what happens when an OCT beam flows through a blood vessel. So at one point, as it flows through the artery, you see that it passes through without touching any RBCs. But the next beam here is getting reflected back at an RBC. So the difference between the two is an A-scan signal, which is deflected back and detected on the screen. And this is processed. And then you get an Opta signal. So it's basically the moving RBCs within the blood vessels that generate the signal. So by this, we can segment and visualize the different layers of the retina and choroid, and you can map the superficial, intermediate, and deep capillary plexus, the choriocapillaries, and the choroidal vessels all separately. So what do you look for? I think this is more of a practical talk. If you're looking at retinal vascular disorders, and the commonest is diabetic retinopathy, retinal vein occlusions, and retinal vasculitis, you need to look at the superficial and the deep slabs. And Opta is an excellent tool for imaging areas of ischemia and non-perfusion. It detects neovascularization. Most importantly, it can image the deep capillary plexus and the radial peripapillary capillaries, which is not possible with fluorescein angiogram. However, many commercial systems have a limited field of view. So this may be a limitation in Opta, though new machines do have wide field. And it also does not indicate if the neovascularization is leaking, though as we go along, I'll show you some clues. So this is a nice article in Progress in Retinal and Eye Research, which shows us the three vascular complexes in the retina. You have the superficial vascular complex, and you have the deep vascular complex, which is composed of the intermediate capillary plexus and the deep capillary plexus. And these are the areas where they are represented. So the superficial vascular plexus is located at the level of the ganglion cell layer. The intermediate capillary plexus is located between the inner plexiform and inner nuclear layer. The deep capillary plexus is located within the outer aspect of the internuclear layer and the outer plexiform layer. Now, what is important for you to know is that superficial vascular plexus and intermediate capillary plexus, they have a direct arteriolar supply from a retinal artery, and there are a lot of interconnections. by numerous vessels on both the arteriolar and venular aspects. But the deep capillary plexus is supplied only by small arterioles which originate from the intermediate capillary plexus. So this makes us realize that the deep capillary plexus is probably the most sensitive to ischemia, and visualizing that on Octa helps us understand diseases a lot more. So as I mentioned earlier, only one plexus, the deep capillary plexus, has a single monoplanar capillary layer on Octa, whereas the other two have a multiplanar architecture. So coming to the most common vascular retinopathy is diabetic retinopathy. What can we see on Octa? If you do a careful Octa, you can see microaneurysms. You can see intraretinal microvascular abnormalities, which you see in the retinal plexus. You can see venous beading and loops, which we know they tell us that it's severe NPDR. And you can identify neovascularization. And what is important in diabetic retinopathy? Octa can help us differentiate between IRMA and NVD because you pick up neovascularization in the vitreoretinal interface slab, whereas you pick up IRMA in the superficial retinal slab. And I'll show you that as we go along. Quantitatively, you can measure the areas of capillary non-perfusion. You can see the vessel density. You can look at the fractal dimension of the vessels. You can measure the fast size and circularity. And you can also look at the vessel length density and the caliber of the venules. Most of these quantitative data is usually a research tool, but qualitative data is very important in our clinics. And also in diabetic retinopathy, we know there is an importance of white scans, because if you just take a 3 millimeter scan, or a 6 millimeter scan, you're likely to miss the extensive ischemia that is seen anterior to the macula. So it's always important to look at a white scan when you're doing a scan for a patient with diabetic retinopathy. And with our understanding of Octa, we've also understood that diabetic macular ischemia, and not only diabetic macular edema, is a new therapeutic target. And we can identify diabetic macular ischemia very well on Octa, probably a little better than fluorescein angiogram, because of our ability to study the deep capillary plexus. So there are three types of ischemia. One is when the superficial capillary plexus is ischemic. This is a milder phenotype. And we all know about the biomarker called DRIL, which is disorganization of the inner retinal layers, which is a negative biomarker for vision in diabetics. Now, superficial capillary plexus ischemia may not always be associated with DRIL, but it can. But because the deeper capillary plexus is well perfused, as you see here, these eyes may not always have reduced visual acuity. Whereas if you have predominantly deep capillary ischemia, like you see here, the superficial capillary plexus is okay, but you see these large areas of flow void in the deep capillary plexus, they may be associated with ellipsoid zone disruption, which we know is a negative biomarker for vision. And this is a better predictor for diabetic retinopathy severity, because these are the eyes that are likely to have a visual loss. And sometimes this mismatch between the flow in the superficial and deep capillary plexus may be responsible for frequent recurrences in diabetic macular edema. And then you have the more severe visual loss when you have ischemia both in the superficial as well as the deep capillary plexus. And at this point, you may get structural OCT changes such as DRIL and outer retinal atrophy. And this signifies a more severe visual loss. Now, this is a clinical example of a patient I saw just a couple of days ago in my clinic. She's 80 years old, a medical professional, spends half our time abroad with her children, has no insurance abroad, has poorly controlled diabetes, and was told by an optometrist that there was a retinal problem. So she came back to India, came and saw me, and she has what looks like mild background changes in both eyes. There are some hard exudates temporal to the macula in the right eye, and there is this pigment hyperplasia due to mactel, as well as a succinate of hard exudates temporally. But if you look at the background retina, it just looks like a few hemorrhages. So I did an octa in her, and this is the right eye. It shows a few areas of capillary non-perfusion. There is a little bit of neurosensory detachment on the P scan and some macular thickening temporally. And if you look at the vitreoretinal interface, you see it is absolutely clean, indicating that there is no evidence of neovascularization. Now, what is important in diabetics? We know proliferation can occur nasally. So always do a disc-centered scan, not only a macular-centered scan, and you may find something nasal to the disc. In this patient, there's some areas of patchy non-perfusion. Now you look at the left eye, it shows you this vascular complex here within the area of mactel. We always know that there can be sometimes some pigment proliferation and some vascularity within that area. And she also has some macular edema temporal to it. This is non-center involving macular edema, a small area of capillary non-perfusion superiorly. Then you do the disc-centered scan and you see something here that is above the retinal vessel. And then you run it through the vitreoretinal interface and you see that she actually has neovascularization here. And if you look at the B scan, it shows a flow signal in this little tuft that is rising above the retinal surface, indicating that she actually has proliferative diabetic retinopathy in one eye. So sometimes when you have elderly patients who do not have a good systemic health, they are not willing to have a fluorescein angiogram. A careful octa can help us find out these abnormalities which require treatment. Now, the other common condition we would do an octa is retinal vein occlusion, and these are the qualitative and quantitative changes that we can see. Again, mainly qualitative changes, which would identify features of poor prognosis, such as areas of ischemia and also collaterals and neovascularization. Again, in retinal vein occlusions, the superficial capillary plexus and the deep, you see that the ischemia in the deep capillary plexus is much more, and correspondingly, you have an area of retinal thinning on the B scan, indicating that these eyes are likely to develop neovascularization. This is another patient with an ischemic BRVO, but this time with macular edema. The ANFAS image shows us the retinal cysts. And if you look at the deep capillary plexus, again, you see a large amount of signal voids. But suffice to tell you that there is adequate perfusion. And this is the deep capillary plexus, again showing that it is fairly well perfused. And this is the patient before and after. You see a good response to ranibizumab. The edema has come down. And then you look carefully at the deep capillary plexus. You see this is pre-treatment, showing fairly good perfusion. But if you look at post-treatment, you see there is a lot of ischemia in the eye, indicating that he's going in for ischemic central vein occlusion. He had subsequently 2 or 3 more injections. And if you see here, there is no edema on the B scan. His visual acuity is good. His systemic parameters are under optimal control. If you look at the B scan, everything is fine. But if you put in your opta, you see the significant amount of ischemia now seen also in the superficial capillary plexus. And 1 week later, we did an OCT and there he had a rebound of macular edema with a neurosensory detachment, improvement on the B scan. If you look at it, everything looks nice, but progressive ischemia, even though visual acuity was maintained. And then we did a fluorescein angiogram, and you see now the significant ischemia in this patient. So he's had a panretinal photocoagulation, requires an anti-VEGF every 2 months, and now I've switched him to Ozurdex, and he's awaiting cataract surgery. Now, if you need to look at choroidal neovascular membrane, the slabs you need to look at are the outer retina, the ORCC, and the choriocapillary slabs. Where OCTA stands out compared to other investigation is the detection of type 1 or sub-RP choroidal neovascular membranes, definitely superior to fundus fluorescein angiogram. It helps us differentiate vascular and avascular components when you have SHREM, when you have to decide whether to treat or not to treat. It's very easy to assess treatment response and recurrences. And most importantly, the detection of asymptomatic CNVM in intermediate AMD, which requires a very close follow-up. So this is a patient with a type 2 choroidal neovascular membrane. There is some SHREM here. And clinically, there was an area of hemorrhage. This patient developed a choroidal neovascular membrane. This is a type 2 membrane. This is before the membrane developed. There was just a yellow fibrin here. No neovascularization was picked up. 3 weeks later, she came with blurring of vision. You see this choroidal neovascular membrane surrounded by hemorrhage. Signs of activity on the B scan. The B scan OCTA has a flow signal telling you this is a vascularized lesion. And this is the response after treatment. You see the membrane has shrunk and the whole lesion has become very compact. And it's helpful also to do a video and look at the lesion. Here you have a patient with a type 3 MNV or the RAP lesion where there is a communication between the retinal and the choroidal circulation. You see this color changing from red to green because you have the blood vessel going beneath the RPE. When it goes below the RPE, the coding for this is green. And you see this communication and the dipping vessel on the unfast view connecting with a deeper, larger complex below. Response to treatment can be very well seen on OCTA. This is a patient before and after treatment. You see that this membrane has shrunk significantly. And it can also show you on follow-up an increase in CNV size. This is the patient who had no activity, but the membrane was present. And if you see the patient a couple of months later, the membrane has increased in size significantly. This part has grown, indicating that chances are this patient will require a repeat treatment when a subretinal fluid develops. Now, this is a case in retrospect. This is the good eye of a patient who had advanced macular degeneration. He had an asymptomatic left eye, presented with sudden drop in vision on follow-up, and there are retinal hemorrhage and a little bit of fluid seen here. The OCT shows the cystoid macular edema and little elevated RPE, and the OCTA shows a small area of vascularization on the unfast view. We know this is how early RAP lesions present. And then I wanted to look back and see, did I miss something earlier? And then when we looked back, this was the membrane that we saw. And we looked back, there was nothing on the scan, either on the B scan or on the OCTA. But when I looked very carefully, took a smaller scan and went extrafoveal, I found that there was actually a much smaller membrane sitting in the deep retinal layers, which had grown and bled in a 3-month time. So we know RAP lesions start extrafoveally and they may not present with visual loss in the early stages. So especially in the fellow eye of a patient with advanced type 3 MNV, we need to look carefully in the parafoveal and perifoveal area because these small little lesions are sitting there. We may not treat them, but we definitely need to keep a close watch. Now, sometimes we need to know whether the lesion is stable or not when you've exhausted all your anti-VEGF agents. So this is a patient particularly resistant to treatment, but who maintains a best-corrected visual of 6/9. You see the sub-RP neovascular membrane and shallow subretinal fluid. This is the anfas of the lesion. You see the tangled sub-RP complex. And the next visit where everything looks the same, but if you look at it, there is a much more tortuosity of the vessels, though the fluid is the same. You see that these lesions are a little more active, and this is when you probably would like to go ahead and treat the patient again. Again, this patient, this is the other eye. You see the sub-RP complex, and you see the straightening of vessels. There is no fluid, but 2 months later, you see there's intraretinal and subretinal fluid on the B scan, and you see these vessels are again looking more tangled. This is the typical medusa and dead tree appearance. And again, once you treat the patient, goes back to the straightening of vessels with less of branching. The sub-RP complex is reduced in size and there is no fluid. And I know we have a discussion on PCV, but Octa is now a good alternative to ICGA in cases of PCV. But what is more important is you look at the vascular signal on the B scan of Octa, which picks up these sub-RP polyps much better. You need to be aware of artifacts, which are plenty in Octa. So it is more important to beware of them so that you don't make a wrong diagnosis. And these are the various artifacts that you can have. It depends on various reasons you can get the artifact, the eye tissue itself, the movements of the patient, because sometimes requires a lot of patience for them to fixate, especially for your high density scans. You can have improper data acquisition or signal processing related artifacts. And I'll just show a couple of them. The unmasking artifact, when you have a lot of atrophy, here you see these tails which mimic flow signal, but these tails indicate that it's an artifact, and this artifact is because of geographic atrophy and not neovascular complex, as you may think when you look at it in ANFAS. And then you have the other artifacts because of patient movement and patient blinking. Of course, you're unlikely to make a mistake in diagnosis, but you may miss important findings. Now, this is a lady with an asymmetric diabetic retinopathy, lost vision in one eye and came for an opinion. This is the right eye, which looked apparently normal, but I asked for a wide scan in this patient. And if you look at it, there's so many artifacts by which I am likely to miss lesions because I was particularly looking at this quadrant. So then you see there is a lot of peripheral non-perfusion indicating significant ischemia, but no definite neovascularization. We went back, checked the scan, repeated again, and then we find there are 2 areas of suspicious neovascularization in the periphery, indicating that she also has proliferative changes in the right eye. And sometimes you have a combination of both. This is a patient with central atrophy. You see the transmission defects. You see the hypertransmission because of lack of RP here. The signals are transmitted down. She also has a peripheral neovascular complex, which is picked up. But sometimes these transmission defects can look like a CNBM. So this is a combination of a projection artifact and a true MNB, which you need to recognize. It's always important to compare with structural OCT scans. This is a patient with proliferative diabetic retinopathy, the wide field Schweppes OCT. And if you look at, you would miss the macular edema here, but if you look at the B scan, you see there's not only macular edema, but neurosensory detachment as well. And it's also important because you may think there's a neovascular membrane, but one, the smaller membrane may be more active, requiring treatment. A large membrane like this may be inactive, requiring observation. And this may be only a projection artifact which you can pick up because of the hypertransmission seen on the B scan. So to conclude, OCTA is based on our ability to image flow in the retinal and choroidal vasculature. And this can be abnormal flow, absence flow, or abnormality in the vessel geometry. If you're looking at retinal vascular disorders, look at the superficial and deep slabs. If you're looking at choroidal neovascular membrane, you look at the avascular or the ORCC slab. Important is to beware of artifacts, especially projection or segmentation artifacts, and always compare with structural OCT to diagnose active leakage. So thank you very much for inviting me to this. And I'm glad to say we are a well-balanced department as far as women are concerned in Shankar Nethralaya. Of course, we are missing the live wire Suganeshwari in this meeting. So thank you.
Mhm. That was lovely, Muna. It makes me feel like wanting to be your student.
Thank you. Thank you.
Yeah. So now I'm going to, it was wonderful, excellent talk, ma'am. That was really nice to hear so much about Okta in detail and to understand it. So we will hold you on for the discussion. Before that, I'm going to invite Dr. Mohita Sharma to talk to us about the WAS and about the women in retina. So she's going to give a briefing on that because this was her idea and her concept. So I'll invite Dr. Mohita Sharma, the person who is like, who thinks far beyond what anybody can think about. So over to you, Dr. Mohita.
Thank you so much, Dr. Signeshwari. And
Hi, Moita.
hello, how are you?
Hi, Dr. Mohita.
Hello. Today only I
Hi,
got to know
Sandhya.
that Signeshwari is called a live wire everywhere. We thought that we had given her that name, but it's nice to know that she's a universal live wire. So
Yes.
So happy to see you all, Retina ladies, on one platform, which was the aim of this Women in Retina group. And I'm especially happy to see Dr. Dhaneshri, who has always been so supportive for WAS. Dr. Muna Binte, whenever we have requested her against all odds, she has always tried to be a part of WAS. And the very enthusiastic Dr. Caro be always there with us and for us, come what may, and of course Praveen Sen and Sandhya. All these ladies have been pillars of support for WAS. And before I start, one is our live wire Signeshwari and the other is Anisha Seth. The two got together and I feel that when both of them get together, it's like they are able to create magic within a very short span of time. When I get worried that program is not happening, now within 2 days they make everything happen, and that's their capability. Thank you, Signeshwari, and thank you, Dr. Anisha. So I will talk very briefly and only about maybe a 4 5 slides about what WAS is and a little about what is the plan for women in retina. So, WAS, as you all know by now, is works on the concept of givers gain. We all believe in giving to each other. There are a lot of societies, a lot of organizations. We see so much of competition. We see so much of pulling down each other everywhere that we thought, let's have a platform where everybody just supports each other. And somehow the culture became that of givers gain, which means that more you give, the more you get back. And that's what everybody has been doing here. And the culture is also of mentoring, so everything is based on mentoring. And the idea is that you are not alone in your professional journey, and that is the idea behind this Women in Retina or wire also. Initially we didn't know what name to give to this group. We thought we'll call it WINAR, but WINAR is already our Women in Research wing. So Dr. Sugneshwari and Dr. Anisha suggested WIRE, which is a beautiful name. So this is basically a Women in Retina wire group. Now, just briefly about what WAS has been doing, will be doing in this year. There will be state chapter meetings which will be happening at all state chapter levels. And I have given photographs of ladies because these are ladies who work behind the scenes and they do a lot of work for all these chapter meets. Dr. Alpa and Dr. Madhavi. Alpa from Hyderabad and Madhavi from Vijayawada. And this year's focus is on skill enhancement. The clinical part, of course, is important, and along with that, there will be a focus on Project Touchna, which is to teach how to deal with dissatisfied patients. On WAS Speaker Bureau, that is making and presenting flawless and impactful presentations. And we have a separate wing apart from Women in Retina wing called there is a wing called Young WAS because this is to do with the age group between 30 to 40 years, which have their specific challenges. Project Shakti is an ongoing project led by Dr. Jimmy Mittal from Lucknow, and this is to deal with workplace challenges. Then we have this Project Archana, again an ongoing project to deal with dissatisfied patients, angry patients, violent patients, or maybe even mobs. Then we have this Women in Research, which will continue its activities with a lot of studies, which there we have multi-centric studies also, which have been initiated already. And the Rare Eye Disease Registries, which is being continued by Dr. Anupama Kiran from Bangalore and Dr. Aishwarya from Odisha. Genetics has been introduced as a new frontier for clinicians, being led by Dr. Deepika Parmeswaram from Bangalore again. Then we have this WAS Care, which will be very active this year. This is about short-term trainings being led by Dr. Shweta Walia from MP. We have this Entrepreneurs Wing, which is being led by Dr. Samina Zamindar from Bangalore. Again, a lot of work is being done on this. And we have this Women in Retina Wing. Thank you to all the ladies, Dr. Chaitra, Dr. Praveen Sen, Dr. Sandhya, Dr. Nisha, Dr. Signeshwari, for the launch that happened during the annual conference. So it's a new journey. So the idea is that one is that we are already working on a website page and in which there will be news and updates about women in retina. There will be educational material and there will be a column for finding a retina specialist. And this will be starting with women retina specialists, but later on, the idea is that we would add on men retina specialists also. Then there will be update sessions. Today is one, and there will be physical as well as online update sessions. There will be trainings related to retina, some certification courses, and mentoring programs. So this is the initial start, and as you all start, you all keep suggesting how to take it forwards, we will keep modifying it. So this is the website. The template is already being made, and it will soon be there for everybody's critical comments as well as suggestions. And this is being supported. The program is being supported by Roche, so we are thankful to them. This was the launch of Wire, which happened during the annual conference. Some of you were there. For others who were not there, this was the launch, which was again a very enthusiastic launch that initiated this Women in Retina group. And today we are talking about Octa with Dr. Muna Bhinde and with all others. And this is the first formal program in the form of a retina update. So we are here to start a new journey. So welcome everybody and all the best to you all. And I always end my presentations with this slide. I alone cannot change the world, but I can cast a stone across the waters to create many ripples. So we are here to bring about small changes which will result in a big change in the life, as in the professional life of women retina specialists. And finally, this is a New Year gift for all those who are yet not WAS members. There's a complimentary WAS membership till 31st of December. And to our surprise, within the last 24 to 48 hours, 1,000 figure has been reached for women ophthalmologists who joined WAS. So we are very happy, and somewhere we'll feel satisfied that maybe WAS is doing what it aimed to do. Thank you.
Thank you, Dr. Mohita, for the wonderful introduction about the WAS and the activities of WAS. So I'm sure you will have many more people joining with the amount of activity that is taking place. So congratulations for that. So now I will request our next speaker to talk about. So we are going to have our young and dynamic consultant from Shankar Nethralaya, Dr. Preeti, who is actually resilient in spite of her son having a febrile seizure today. She still decided to speak on the topic which she had agreed to give up on. So this talks about the women power, how strong they can be. They were trying to balance both the family and the professional career. So Dr. Preeti is a vitreoretinal consultant in the department of Sri Bhagwan Mahavir Vitreoretinal Services, Shankar Nethralaya. So Dr. Preeti, you can discuss your case today. Thank you for being here.
Thank you so much, ma'am. Good evening, everyone. So, I'll share my screen. Are my slides visible?
Yeah, now it is visible. Yeah.
Yeah. So I'm going to discuss a case-based discussion on a OCTA in CNVM. So it's regarding 60-year-old female presented with blurring of vision in left eye for 1 month. So her right eye discorrected vision was 6/9 with N6 and left eye was 6/60 with N80. Her intraocular pressure is normal and anti-segment is normal in both eyes and lens NS2 cataract. Fundus, the left eye shows a thick fibrovascular membrane surrounding subretinal and subretinal fluid and subretinal hemorrhage. So OCT B scan shows a thick fibrovascular membrane above the RP suggestive of type 2 CNVM. The significant subretinal fluid and subretinal hemorrhage, and it shows some cystic spaces and intraretinal fluid. So avascular slab shows the avascular slab of OCTA and on first image shows a tuft of branching vascular network, which the structural and first image shows anatomical extent of the fibrovascular membrane with subretinal fluid and the subretinal hemorrhage, and it's depicted in the OCT B scan also. So here you can see some flow signals, which is depicted by the green color coding, which shows there is some neovascularization happening in the avascular slab, which is usually devoid of any vascular structures. In ORCC slab, you can see a tuft of tangled branching vascular network with a halo, surrounding halo. This is also repeated in ANFA's image with a which gives a topographical extent of the lesion, and it has a large irregular hypo and hyperreflective patches over the macula, which corresponds to the fibrovascular complex. And you can see the B scan with a flow signal. So the patient received 2 monthly doses of intravitreal ranibizumab, and he underwent cataract surgery with the 3rd dose of ranibizumab in left eye. So now you can see the response of the serial avascular slabs of the patient. At presentation, there is a quite large network of vessels which has gradually reduced after the first dose and further reduced after second dose and third doses. So if you see the B scan of the OCT at presentation, there's a quite large shrimp present with subretinal fluid, which is reduced significantly after the first dose of injection and with subsequent injections. The same you can see with the ORCC slab also. The corresponding B scan also shows a resolution of the subretinal fluid and subretinal hemorrhage, and the density of the network and the capillary fringes have reduced significantly with the 3 doses of injections. So at 6 weeks after third dose of ranibizumab injection, the patient best corrected visual acuity was 6/6 with N6 in left eye. And so OCTA findings in regression of CNVM. So we see decrease in flow signals within the CNVM network. There's a large mature vessel with less branching and loss of fine capillary fringes. This is called pruning of vessels, reduction in the size of network and resolution of subretinal fluid and more compact shrimp. This is my case. And thank you.
Thank you, Preeti, for the very nice presentation. So now I'm going to request Dr. Parveen Sen, who is also, I would say, she has been predominantly a part of Shankar Netralaya for very many years. So, Dr. Parveen Sen, ma'am, are you there? Ma'am, you'll have to unmute.
Yeah, I'm here.
Yeah. So now the question to you would be the relevance of segmentation in terms of when we are trying to see these neovascularization.
Yeah, I think it's very important because this is which will decide whether you are dealing with a type 1 or a type 2 membrane. And both of the membranes can differ uh, in response to treatment. So it is important to look carefully for the segmentation. But it's not always possible. Like sometimes in a very large membrane, or when there is a lot of scarring, or there is pigment epithelial detachment, or there is subretinal blood, sometimes this segmentation can go really haywire. So then you have to look at multiple clues to really know whether you are looking at a sub-RPE or a pre-RPE lesion. And you can't always rely upon the automatic segmentation which is done by the machine. So you may have to sit down yourself and then change the segmentation lines so that make sure that they follow the configuration of the RPE, and then you take a call on whether you are dealing with a type 1 or a type 2 membrane.
Thank you, madam, for the wonderful explanation that was given. And I think, yeah, that is really important that auto segmentation one cannot rely on. And what my next question would be, where do you see the limitation of Octa comes in terms of dealing with CNVM?
I think one of the major limitations is probably a myopic CNVM, where you would get a lot of artifacts, and it's very difficult to delineate exactly where is the CNVM, and the choroid is so thin and tessellated that you will not be able to delineate a myopic CNVM very well, even though it is a pre-RPE membrane. And the second thing is when in presence of a lot of hemorrhages. Third is in presence of a very high pigment epithelial detachment. And these two can happen in cases of polypoidal choroidal vasculopathy. Again, Octa may not give you too much of information in presence of large areas of subretinal blood or pigment epithelial detachment. Another peculiar example can be in presence of asteroid hylosis, where again your view may be hampered because of the presence of vitreous opacities. And in those cases, FFA may actually be better than OCT angiogram. Though in our clinical work, especially where neovascular membrane is concerned, I think we have gone over from dye-based angiography to OCT angiography. Diabetic patients still probably it will have relevance in quite a few scenarios, but I think for neovascular AMD, this is something which we really depend upon almost 99% of the times.
Thank you, ma'am, for all the wonderful remarks that you have made. So now I will move on into the inviting the next speaker to talk about. Our next speaker is going to be the person from Arvind Eye Hospital, Dr. Shivaranjani. She is a consultant in Arvind Eye Hospital, Pondicherry, who is going to be talking about uh, Octa in diabetic retinopathy. And she's been doing extensive work on that. And I believe they're going to come up with a very large study on diabetic retinopathy, which we will all be soon seeing as a publication. I think they're all doing it. Dr. Manvi and Dr. Shivaranjani has been working on that. So now I will invite Dr. Shivaranjani to speak on Octa and diabetic retinopathy. Over to you, Dr. Shivaranjani.
Good evening, ma'am. Are my slides visible?
Yes.
Yeah, Shivaranjani, yes.
Yes. At the outset, I would like to thank Women Ophthalmic Society for giving me this opportunity. My topic is OCT angiography in diabetic retinopathy. Our first patient is a 53 years old female. The patient presented to us with a defective vision in both eyes for 8 months. Her best corrected visual acuity was 6/9 in both eyes. Fundus features suggestive of severe non-proliferative diabetic retinopathy changes. She is on dialysis for 6 months. So this is a fundus photo in both the eyes. We can see the severe NPDR changes. At the same time, we proceeded with the OCT and OCT angiography. We can see in OCT diabetic macular edema with a few IRF spaces involving the fovea. At the same time, a perifoveal exudative vascular network-like lesion can be seen just nasal to the fovea in a parafoveal space. So we proceeded with the 6/6 mm OCT angiography, in which we confirmed the PVAC lesion, and the corresponding the lesion is noted in the OCT B scan. In the other eye, we can see the normal fovea contour in the OCT and non-central involving DME. And we did the OCT angiography of 6/6 mm slab and the corresponding OCT B scan. So till now, the feature suggestive of NPDR changes. Then we proceeded with the montage angio of 8/8 mm. So here we can see the multiple capillary non-perfusion areas in the right eye. Here we couldn't find the actual neovascularization in the right eye. But if we concentrate this yellow circle area in the VR interface lab, we were able to identify the vascular network in this patient. In the left eye of angiography, this picture shows the angiography 12/12 mm. We were not able to identify the vascular network. So we proceeded with the diagnosis of right eye proliferative diabetic retinopathy with the diabetic macular edema, and the patient received panretinal photocoagulation, 2 sittings in the right eye, and in left eye we observed with the systemic control. Our second patient is a 61 years male, history of diabetes for 8 years. He presented to us with a defective vision in both eyes for 9 months. The patient's best corrected visual acuity was 6/9 in both eyes. In the right eye, fundus DR changes were not gradable due to the asteroid hyalosis, and in the left eye, severe NPDR changes were noted. And because of this finding, we proceeded with the fundus fluorescein angiography. We can see NPDR changes in the right eye, but left eye had neovascularization of the disc and neovascularization elsewhere. We proceeded with the OCT with the normal fovea contour, and OCT angiography, we can see just nasal to the fovea, a hyperreflective lesion with the corresponding B scan. OCT B scan showed positive force signals which suggestive of foveal neovascularization in the right eye. And in the left eye also, OCT, we can see non-center involving DME with a hyperreflective lesion just superior to the fovea, and the corresponding OCT angiography of 6/6 mm superficial capillary plexus, and the OCT B scan was done. The same eye in VR interface, we can see the hyperreflective lesion with the corresponding positive flow signals is noted. So we pick the foveal neovascularization in the VR interface lab. In the right eye, we came to the diagnosis of severe non-proliferative diabetic retinopathy with subtle foveal neovascularization. In the left eye, grossly it is proliferative diabetic retinopathy with fovea neovascularization. The patient received left eye PRP 2 sittings. For DME, the patient received the anti-VEGF injection, and we explained the systemic control. To our experts in the panel, foveal neovascularization in DR, because the second patient had rest of the area non-proliferative diabetic retinopathy changes. So in one eye we observed, the other eye we went for the PRP in foveal neovascularization in DR. Do we still consider PRP or anti-VEGF or observe? And in both the patients, we identified the neovascularization in the VR interface lab. And in our setup, we find less patients with the neovascularization in the superficial capillary plexus or in the deep capillary plexus, and most of the patient we found it in the VR interface lab. So we would like to know about the experts' experience also.
So now I'm going to request our expert panel here to discuss on the questions which Shivaranjani has thrown forward. So may I request Dr. Karubi madam to kindly pitch in and sort out the questions which Shivaranjani has thrown here.
Shivaranjani, I saw that in the right eye you resorted to only laser photocoagulation, whereas no anti-VEGF was given. I think an anti-VEGF would be in order for the right eye, because the
Okay,
thing is that that would help with the neovascularization, as well as the peripheral elements would get treated because of this. The patient did have a lot of diabetic macular edema, so that
yes.
warranted a anti-VEGF injection. At least if it was my patient, I would have given a combination of both. And I think wherever you get a foveal neovascularization, it is better to resort to an anti-VEGF, just not only to laser treatment for the remaining lesions in the retina.
Yes, madam. Thank you, ma'am.
So, may I request Dr. Dhanashree Ratra, ma'am, do you have any difference of opinion, or would you agree to what Dr. Karubi ma'am has said?
Hi, Sugneshwari. Yes, it is sometimes difficult to detect the neovascularization, but I would agree with Dr. Karubi that maybe it would be good to do a combination, but of course, PRP is the final treatment, so PRP is a must. But sometimes in very early stages, and anti-VEGF can also work, especially if there is also concomitant macular edema, then anti-VEGF will be a better option.
So I have a question for the panel. The how many anti-VEGFs in such kind of a case where there is some amount of macular edema and there's not much of peripheral CNP areas, how many injections do we need to give? Do we follow up the regression of the foveal neovascularization, or how many injections should we give? Because otherwise we give by the we titrate according to the DME on OCT. And here we don't have much of macular edema, but basically a foveal neovascular vascular lesion right at there at the fovea, and not much CNP areas as well. So how do we go about it?
So actually, if I can answer this question, there is no finite answer. And I mean, we do not know how many number of injections will be required. So, but there are patients, like I have a few patients who I'm maintaining on these anti-VEGF injections. Initially, we give aggressive therapy, we give probably monthly injections. But what happens is that this neovascularization will become inactive for some time, and then you will see after 6 months again it will grow. So I have seen that the same neovascularization will become active again. So that means you will see the growth of from the same complex. So probably you need to keep repeating injection, but how many, that will be difficult to tell. But it was of course always advisable to have them on a periodic follow-up. So there are patients in whom now I'm maintaining them on every 6 months anti-VEGF injection. Of course, PRP also has been done, but they do require periodic injections.
Anisha, if I can answer this, I would say that I would give the loading dose definitively of the injections, and then I would go PRN and see that the diabetes is well controlled, because the thing is that that is the key to all these formations again. So the thing is that that would be my take, and repeatedly, keep evaluating whether there is a need or where there is an upsurge of any kind of lesion which requires treatment.
Actually, if I may add there, for me, I think it is the DME which will determine the number of injections, because neovascularization is not a problem. The response is very quick and the patients respond very quickly. The NBE will show regression, especially in the absence of fibrosis. So, and since you've already decided to do a combination treatment and pan-retinal photocoagulation is there, that should prevent the recurrence. And as ma'am said, later on you just have to worry about the recurrence of the NVE or the DME. But initial response of NVE to injection is very, very quick. You don't need treat and extend and all that for NVE.
Yeah, Dr. Praveen, but I've seen that these macular neovascularization, sometimes they're very recalcitrant. They keep coming up, as Dr. Karabi said. They keep coming up every few months. You know, you've done a PRP, good PRP, and you've done the anti-VEGF, but every few months, the NVs at the macula somehow they tend to reactivate, and you would need to keep these patients under very close
So the
follow-up.
recurrence is a major problem. Initial
Yeah.
response is very quick, but the
Yeah, but
recurrence is the major
recurrence
problem.
is somehow they just keep recurring, and you have to keep repeating the anti-VEGFs every few months.
Ultimately, I think you'll end up operating because they develop
Yeah,
TRTs and macular TRT starts happening.
yeah, ERMs.
So I think with that we had an excellent discussion on the macular neovascularization in diabetic retinopathy. So we will move on into the next speaker. So I shall invite Dr. Sneha Giridhar, who is a consultant vitreoretinal surgeon, who has just now completed her fellowship from Moorfields also, apart from finishing her fellowship in Shankar Nethralaya successfully. So she is a vitreoretinal consultant in Giridhar Eye Institute, Kerala. So I'm going to invite her to speak on Octa in PCV. Over to you, Dr. Sneha.
Thank you, ma'am. Thank you so much. I'm just sharing my slides. Yeah, I think my slides are visible.
Yeah, your slides are visible, but you're not visible.
Oh,
I guess everybody would like to see you also.
yeah. Sorry. Yeah. Yeah. Okay. Okay. So, good evening, all. I would first like to thank the team for this opportunity. I'll be speaking about the role of Octa in polypoidal choroidal vasculopathy. Okay, so PCV, as we all know, it's characterized by dilatations, polypoidal dilatations of a branching vascular network that cause exudation and hemorrhage, which are seen as subretinal nodular hypofluorescence on ICGA. So Octa has this advantage as it's non-invasive modality and that detects flow signals within these PCV lesions. Octa demonstrates greater sensitivity for detecting branching neovascular networks due to its higher flow rates as compared to polypoidal lesions because it exhibits a slower filling. This accounts for one of the limitations of Octa relative to an ICGA in polyp identification. So going on to our case, this is a case of a 73-year-old female patient complained of declining vision in her left eye within the last 3 months. OCT over here, it demonstrates the classic features of PCV, including double layer sign and a notch PED. While ICGA on the top right images, it shows polypoidal lesions very well, but the branching neovascular network is not seen very clearly. So this way, I feel that Octa has helped in understanding these branching neovascular networks. So just to understand the slab and how we do a manual segmentation, on the left-hand side, it's a choriocapillary slab, which is an automated slab, where we can't pick up these network very easily. But if we correct the slab as in we bring the inner edge into the RPE and the outer slab towards the Brooks membrane, on the B scans, we are able to trace the branching neovascular trunk on the NFAS Octa images. And if we bring to it, oh, sorry, this has been here. Okay. And if we bring the slab towards the tip of the PED, where usually the polypoidal changes are seen, we may be able to pick up a polyp as seen over here as a hypoflow round structure arising from a neovascular network. So these can be compared and with the flow signals which are seen on the B scan, and we can see that in the B scan corresponding to the branching neovascular network, the flow is more compared to that of the polypoidal area where you have a decreased flow. This is another case where the OCT depicts classic PCV features. So here the pigment epithelial detachments, you've got notched pigment epithelial detachments which are seen in clusters, and the characteristic hyperreflectivity that is seen towards the tip of the sub-RPE space. So Octa here shows the branching neovascular network trunk and possible leading to the polypoidal dilatations. So here following treatment, the OCT, it shows a very good response with flattening of the PED, possible even regression of the polypoidal structures. The Octa shows mature network and also possible regression of the polypoidal structures. But again, here we can't comment on polyp closure, which will be better detected on ICGA. Octa is also valuable during follow-up. This patient was treated with intravitreal anti-VEGF treatment and has been on 4 to 6 monthly follow-up. Although the structural OCT shows a dry scan, the OCTA shows an enlarging neovascular network, indicating that the patient needs to be seen closely for a possible disease reactivity. And as Dr. Parveen Sen ma'am mentioned, the major limitation of Octa is in eyes which have a very tall or like a large hemorrhagic PED, where the Octa shows maybe a large homogeneous signal void, and the ICG very nicely it picks up the hypofluorescent nodular change towards the tip of the PED. Other limitations being other hyperreflective pathological structures like exudates and also polyp lesions because it has a lower flow. That's all. Thank you.
Thank you, Dr. Sneha. That was a very nice and a crisp presentation on Octa and PCV. So now I would like to request our panelist to answer a few questions on how do we follow up. I mean, would they really prefer doing an Octa on a follow-up patient with a PCV? So, Dr. Sandhya, would you like to take that question? Sandhya?
Yeah. Yes, I'm here.
Yeah. So,
Sorry,
yeah.
some network issue in my place.
So did you hear the question or would you want me to repeat it?
Yeah, can you please just repeat it,
Sure.
Sugneshwari?
Yeah. So what I wanted to ask was on a follow-up patient of PCV, would you like to do an Octa whenever you follow up a patient, or would you like to do it only at the beginning or at times when you feel that the patient is not responding? When would you like to do the serial follow-ups of Octa?
See, in my opinion, I mean, Octa is such a non-invasive that you can practically do every visit, so there's no issue at all. But honestly, I mean, if you ask me that how much information I gain from it, so I don't do it very closely as I do, OCT. I do a baseline, then probably I'll do probably a 3 monthly or 4 monthly Octa. And in fact, ICG and FFA, probably a combo of ICG and FFA, I would like to repeat in between. That's my
Sure.
protocol. Yeah.
Yeah. So, and now I would like to ask Dr. Muna Bende about the serial follow-up using Octa. When and where in your practice would you like to use Octa for follow-up in PCV patients?
I would do after every injection, because I think we've become more comfortable with Octa and PCV. And probably in this, I would differ with Dr. Sandhya, in which I would probably repeat a fluorescein ICG. I do very little fluorescein ICG even for PCV now. I would probably do it if I'm not sure if the response is not what I expected, and if I think there may be something else that's getting in the way, then I do it. But since the Octa and OCT is on the same machine, I don't think it makes
Yeah.
much of a difference for
It
us to
doesn't.
repeat
It
it. I
doesn't.
would
Yeah.
definitely repeat it every time.
Can I
But
make a comment
maybe,
here?
I mean, I just want to put my opinion. Maybe, I mean, to be very honest, I'm still in a learning phase as far as Octa is concerned. So whenever I do Octa, a second revisit of Octa, I always find, some different findings which somehow I can't correlate with the baseline ones. So maybe that is the reason I'm little, pulled away from Octa. So I think I just tell myself, okay, let me do an FFA and ICG combo, especially in cases with PCV where I want to get the correct information. So maybe it's my learning phase, which is now not really, helping me to do Octa in every case. Maybe.
Sure,
Sandhya, I think
yeah.
the segmentation has to be proper, because if you do
Yeah.
segmentation properly, you could be at the same plane. So that is something which has to be perfected for the Octa. And I'd like to make a small comment here. I mean, I completely agree with what Muna says, that it is best to do an Octa for a PCV at everything. But let's see a scenario where you don't have an Octa on your premises. Okay, most of the people have an OCT. So an OCT is something which you repeat even when the patients come for a 1 weekly visit or a 1 monthly visit or a 2 monthly visit. You generally do it. But when you don't have an Octa, the thing is that how do you manage? Either you have to manage by sending the patient to the center which does an Octa and come back, where the compliance of the patient again goes down, or probably for people who do not have an Octa on their premises, you do it maybe after 2 injections or 3 injections, and you titrate whether the injections have really worked towards getting the BVN and the polyps and all down, and whether the vascularity has gone down, etc. That would be my take. Let's hear what Muna has to say.
Yeah, Karobi, I think probably the question what Suguneshwari worded was different. How often would you repeat an Octa, assuming you've done it the first time? But there are definitely OCT clues to identify polyp regression. I don't think there's any problem in doing it. And if you don't have an Octa on hand, provided your B scan before injection identifies the lesion, you can definitely follow it up. There are enough OCT clues which can tell
Yes,
you,
yes.
yes, the lesion is regressing.
Agreeable.
So I don't think that is an issue at all. Parveen, you want to say something?
Yeah, I agree. I agree. So that there are many uh, OCT clues which are there to tell you not only in follow-up but diagnosis also. You need not have ICG or Octa to diagnose PCV. Your B scans on OCT are enough to tell you, and I think we have enough publications on this as well, where the Asia Pacific Society of Retina Imaging, they have put up minor and major criteria for diagnosing PCV based on OCT. So we don't need it. But having said that, as Dr. Signeshwari had asked the question, how often would you repeat it? I agree with ma'am that once I have done OCTA, and this being in the same machine, both OCTA and OCT is what I would repeat every time. And as Sneha showed very nicely, sometimes you don't see an increase in the fluid, but you see an increase in the network. And those cases, I sometimes decide to inject rather than wait for the fluid to come, especially on follow-up, not before that, on follow-up, especially if the patient finds it difficult to come again for a follow-up very quickly, because we know that they can suddenly bleed a lot as well, and we may lose the patient or lose a lot of vision. So if I see a large BVN without fluid in initiation, I would not treat. But if I see that there is a large BVN uh, where fluid has come down, but the size of the BVN has increased on follow-up, those are the situations where I may consider repeat injection. So I would want to do an OCTA at follow-up as well.
Can I ask a question?
Yes, please.
Uh, what features would you see on Okta to decide when to switch the anti-VEGF in PCV?
So I think it's the non-response again. If you don't see a in PCV, actually, it's not difficult to look at the non-response, because sometimes in front of your eyes you may actually see an increase in serosanguinous PED, or you may see increase in bleeding, or you may actually see the size of your serosanguinous PED becoming taller. So those are all. PCV is not as easy to respond to anti-VEGF as a neovascular AMD, and you will have to probably give monthly injections, and it is very difficult to take these patients to beyond 6 weeks very quickly. So at each stage, you have to monitor them very closely. They will come back with a recurrence. They keep coming, and that is because polyp regression takes a longer time in response to an anti-VEGF treatment. This is where we miss our PDTs. So I think any increase in, I may even say that there will be increase in fluid, increase in hemorrhage, increase in the height of PED, even when the patient is on one particular anti-VEGF. You can definitely want to switch. And the traditional definition of non-response is that after 3 injections, if you don't see an adequate response, you can switch.
Okay.
So that was a good roundup on the PCV in Octa. So now I would like to request Dr. Our next speaker, who's going to be Dr. Meenal Sharma from the Shroff's Eye Center. She's a consultant pituitary surgeon. She is going to be speaking on Octa in retinal vein occlusion. Dr. Meenal Sharma.
Hi, good evening.
Hi, good evening. Yes, now the stage is all yours.
Thank you, ma'am. Good evening, everyone. So first of all, I thank Dr. Sugneshwari for inviting me here today. So I'm going to share the screen now. Is it visible?
Yeah, Meenal, it is visible.
So the topic I've been given is Octa in RVOs, and I think most of it has been covered by Dr. MPV already. So I'll be talking about 2-3 case scenarios on how Octa is helpful in clinical practice. So why do we need angiography in RVO? Basically to delineate the ischemic area. I'm not able to see the title of the slide. How do I remove the tab? Anyway, so basically it is done to delineate the ischemic area, and we all know the gold standard is FFA, but of course we know the disadvantages as well. Particularly in RVO cases, the main disadvantage is that it gives us a limited depth information, which means that it does not image the superficial and deep plexuses separately, which is very important in cases of RVO, like already discussed, and we'll discuss again. On the other hand, OCT angiography is very helpful, being non-invasive, quick. It gives you depth resolved images where you can image different vascular layers of the retina, and it gives a better delineation of foveal avascular zone. Disadvantages are artifactual projections, inability to detect low flow, and a restricted field of view as compared to FFA, and also its inability to show leakage. So there are various microvascular changes in RVO, and we'll discuss some of them as we go along. So this is the first case of a 57-year-old female who came to us with diminution of vision in the left eye since 2 months. Visual acuity was 6/36. And as you can see on Optus image, there is a superotemporal BRVO. You can see the hemorrhages and scleroid vessels. And OCT shows macular edema with the neurosensory detachment. So we did angiography for this patient. After a couple of months, she received anti-VEGF for 2 months. And here we can see that on Octa, there are areas, CNP areas, and they are visualized much better than we see on fluorescein angiography. And probably here we don't see the microvasculature as well as we see on Octa here because of blockage due to hemorrhages present here. So in this way, Octa is much better, one, because it delineates the CNP areas much better and more clearer way, and it gives probably more, we can see more avascular areas as compared to fluorescein angiography. Here also in this patient, the capillary non-perfusion areas are delineated very well, seen beautifully. So these are the areas or gray zones where there is absence of capillary bed between terminal arterioles. And in RVOs, these areas, CNP areas, are more extensive in deep plexus than superficial plexus. And literature says that CNP on Octa were slightly larger than that on FFA. But one has to be careful that the absence of visible vessels in CNP areas is it can be either because of total absence of flow or sometimes due to decreased blood flow or sluggish blood flow, which is below the detection threshold of the device. This is the second case of a 68-year-old male, known case of BRVO. Already received anti-VEGF elsewhere, came to us with a visual acuity of 6, 9, and 8 in the right eye. And this is the OCTA, 6 by 6 of both the eyes, right and left. Left is given for comparison. Here we can see that the foveal avascular zone looks little distorted and a bit enlarged as compared to the left eye. This is the superficial slab and this is deep. We can see that the area is more extensive in deep plexus. But one has to be careful whether it is enlargement or it is an artifact, because if you look at the corresponding structural B scan and cross-sectional scan, you see there is presence of CME, and you can see these cystoid spaces on FAS as well. So it is quite possible that we are overestimating the area, the ischemic area. One, it can be because of inaccurate segmentation, because the anatomy of the fovea is altered. And second, it can be shadowing due to the fluid which is present in the cystic spaces. And third, sometimes the cystic spaces, they move the capillary vessels away. So that can also lead to signal loss. So FAZ and RV on OCTA, one, the enlargement is more in the deep plexus. And second important thing, which the literature says, is that the degree of disruption of the perifoveal capillary network correlates very well with the presence of peripheral ischemia on FFA. So it's very unlikely that if, this is what the current literature says, that if there is intact FAZ, it's unlikely that there is peripheral ischemia on FFA. So this is the same patient's montage. Periphery did not show any CNP areas, so we did not go in for a fluorescein angiography for this patient. And this is the third case of a 76-year-old female. She had diminution of vision in the right eye since 2 years, known case of BRVO, treated with anti-VEGF and PRP elsewhere. She came to us with CME, and later injection was also given. But this was the OCTA montage taken at that time. Here we could see a lot of CNP areas and collaterals and some suspicious lesion over the disc, which was most probably disc collateral. Here we can see it more clearly with the corresponding color image. OCTA can help differentiate disc collateral from a neovascular front, because disc collaterals will be present in the superficial peripapillary plexus, as opposed to neovascular front, which is seen at the vitreoretinal interface. So OCTA in RVO has certain advantages, like it can delineate changes in both superficial as well as deep capillary plexuses. It helps to differentiate optic disc collateral vessels with neovascular fronts, and it is better than FFA in visualizing the microvascular changes in RVO. And this study says that OCTA picks up micro aneurysms, capillary changes, and collateral vessels much better than ultrawide field FFA. But you have to be aware of the artifacts. They can be shadowing due to edema or hemorrhage, which can lead to overestimation of CNP areas. Of course, there are segmentation artifacts, so there can be difficulty in finding the superficial and deep plexuses. So you should, there's a learning curve to this. If you can learn to do a manual segmentation, that really helps. So it is time consuming, so you can take some time out and do it after the OPD, but that really helps. And then the motion artifacts, usually because of low vision in these patients. So these were some scenarios. Thank you so much.
Thank you, Dr. Meenal, for putting very nicely OCTA in retinal vein occlusion. So now I'm going to request our friend who is sitting from Jodhpur, from the Kamdar Eye Institute, Dr. Rajshri Hirawat, to tell us about what would be her take on using, the type of machine. Like, for instance, if you have available both the spectral domain OCT and the swept source OCTA, in relevance to the diseases, which machine would she like to adopt to? Rajshri?
Good evening, ma'am. So,
Hi.
hi, ma'am. So, if we talk about the RVOs and if we talk about the PCV, the pathology, underlying pathology is totally different. So, in PCV, definitely you want that more depth because the primary pathology at the level of the choroid. So, definitely I would go ahead for the SSOC octa. While in the RVOs, yes, I would be comfortable with the standard just not that SDO octa. So for the PCV AMD, definitely I would go for the SSOCT or uveitic CNVM, where you know the pathology is all around the choroid and retina sometimes is secondary involvement or a vice versa. But RVOs, yes, I'm comfortable with ST octa.
Yeah. So that is a point to be well taken, and that is well said also. So now I will request Dr. Isha to tell us about how she would like to, we all believe that we need a good signal strength. How will you try to reduce or rather alter the signal to the noise ratio? Because once you get a good image, only you'll be able to interpret. Dr. Isha, would you like to highlight on that?
Yes, ma'am. To improve the SNR, sometimes we put the lubricating eye drop so that the patient is comfortable and explain the patient the process. And while taking the image, if we see there is some central cataract, sometimes we can take the image obliquely so that we are able to image the area of interest better and improve our SNR.
Yeah, so that is important. Like lubricating the eye is very important to get a good image so that we are able to interpret well. And that was very nicely explained by you. And now, Dr. Sampurna, Sampurna, are you there? Sampurna? Okay, so if Sampurna is not there, I think then Dr. Isha, then you can take, I just would like you to quickly summarize to tell that the importance of each layer in terms of layer correlated with the slabs. If you can do that, that will be the most important take home message, what we would gather from.
So, ma'am, Octa basically tells us about the superficial capillary plexus, intermediate capillary plexus, and the deep capillary plexus. As Munna ma'am told us in the beginning that the most important plexus is the deep capillary plexus because it has a scanty supply from the superficial and intermediate plexus. So when we are doing the slabs, the superficial capillary plexus can be seen in a separate slab, which comes by the same name. Same way, we can image the deep capillary plexus, which comes by the same name. These are for the vascular disorders like RVO or diabetic retinopathy. If we go to AMD or PCV, our area of focus is on the outer retinal choriocapillary complex, which is ORCC, or sometimes the CC, choriocapillary, where we can manually segment, as we saw in Sneha's case. If we increase the size between the inner and the outer line, we can better capture our lesion in the maybe the type 1 lesion can be captured better. So based on our pathology and our manual segmentation and these slabs, we can see our lesions better.
So that was, good way of putting things together. And Sampurna,
Yes, ma'am. I was finding difficulty to unmute myself.
oh,
So I missed it, ma'am.
no problem. So I would like to ask, rather understand, like the relevance of using an octa in a patient with microaneurysm. So how would you like to use, because in most of the diabetic retinopathies, we all see succinate retinopathies. And how would you like to do? Because in the initial past, the teaching was when a fundus fluorescein angiogram is done, you would like to probably address that, or rather use the laser, focal laser to treat the microaneurysm. In your practice, how would you like to deal with a microaneurysm and use octa in addressing the microaneurysms?
Yes, ma'am. So nowadays we are I mean, leaning towards the anti-VEGF injections in case the patient is developing diabetic macular edema. But in case the patient is presenting with cercinets and we can see clinically evident microaneurysms inside them, then we are still doing focal laser to them, ma'am. Sometimes with or sometimes without anti-VEGF injections, and we are finding good results as well. And if we are doing OCTA for that patients, I mean, we can do Octa for that patients, for those patients, where we will be able to see the exact number, location, everything, location of the microorganisms and their number as well. And we can see, and for the serial follow-ups, if you are injecting the patient or doing laser for the patient, if you are doing repeating the same Octa scan in for the serial follow-ups, then we can get to see the change, how is it changing along with the treatment. So it'll tell us about the prognosis, about how the patient I mean, how the diabetic nature of the patient, how the diabetes is improving, or is it is deteriorating for the patient, like that.
Yeah. Thank you, Sampurna, for the comment. Yeah, Dr. Tinku, you would like to
If
add
I may
something?
add,
Yeah,
so
please.
microaneurysms are very low flow lesions, and sometimes Opta may not pick up the
Yeah, it will not.
microaneurysms very
Yes.
well.
Yes,
So,
yes.
and sometimes even hard exudates you may, confuse on Octa with the microaneurysms. So I think if I were to do a focal laser, if I were planning a focal laser for the patient, I think my go-to investigation in that case would be an angiography, which would show me the areas of leakages. So Octa is not going to show me which microaneurysms are leaking and which are not. So
Yes, ma'am.
before I
Obviously.
plan a focal laser, I would definitely like to do an angiography. I don't
Yes,
know.
ma'am.
To
Of
ask the
course,
other
we have to.
colleagues.
Yes, FFA
Actually,
is
the
better
most
to pick up leaking microorganisms. Definitely, it is much better to pick up leaking microorganisms comparing to Opta, ma'am. Definitely for the low flow.
Yes. So
So
for
this is the most common question that even an audience has asked, and I would ask all the panel experts to let us know what are the conditions where actually you have replaced Octa fluorescent angiography with Octa in your clinical practice. In what all conditions is it absolutely gone? The angiography in is there any condition where you don't need angiography at all? Or I mean, how to decide when to go for angiography and when to go for an Octa in a case? And that is the question that the audience are also asking. So I think we'll start with Dr. Munna.
Yeah, I think I've moved away from dye-based angiography for a lot of conditions, except probably CSR, where, unless I'm suspecting a CNVM, in which case Opta definitely would prefer. But for AMD and PCV, I very, very rarely do dye-based. In fact, almost never. I would still do FFA for a diabetic if possible. But otherwise, a good alternative is to combine a color photo with your Octa and OCT, and then you can pick the microaneurysms quite well.
Dr. Sugneshwari, your opinion on this? You also.
So, see, for me, I would say that, see, because I'm a person who still deals with tumors. So, for me, angiogram is still there effective to play a role, because when we talk about, though of course we can do with Octa, but when we talk about choroidal hemangiomas and all those lesions, still I would prefer doing an ICG, FFA with an ICG, because many a times you would be able to differentiate that better, especially when you have smaller lesions. The larger lesions is not a problem, but when you have something very small, less than say 2 millimeter, then I would still have the dye-based lesions, which are very much necessary in my practice, though. But apart from that, in terms of AMD and PCV, definitely yes, I would not prefer to do an dye-based investigation. But in diabetic retinopathy, yes, in certain cases, like wherein you would like to see how much of peripheral non-perfusion areas are there, that you would still want to do, unless and until we probably get a very wide field Octa, where you will be able to do 25 millimeters. Once that is going to come, I'm sure that is going to replace in a lot more, in terms of us not going to be using a dye-based investigation. But I would still say FFA and ICG has still a role to play in many conditions. But of course, in certain conditions, yes, Octa is always there to be used for the treatment. Yes.
Dr. Karobi and Dr. Praveen?
For me, I think I agree with Mona that I generally do it only for CSRs because you have to know where the leak is, which is the first point of leakage. And in if there are peripheral lesions in diabetics, that's the only place where I would do a fluorescein angiography. Otherwise, an OCT octa is the favored sort of investigation of the day.
I think I'll add extrafoveal polyp to it. If there's an extrafoveal polyp, there's no point treating it with anti-VEGF. You want to target it with thermal laser. That with the CSCR. And yeah, if you are going to do focal laser for a diabetic patient, then as Dr. Tinku Bali said, it is FFA which is preferred. Though, of course, MAs may be seen on OCTA also. But if you're anyway going to do laser, you might as well do a fluorescein angiogram and then follow by laser.
So I think it's safe to say in CNVM and AMDs, it's quite replaced the angiography, but all the other conditions, we still have to see how much. Because I believe even in vascular occlusions, sometimes you do need to do a dye-based angiography, as in diabetic retinopathy also, to see the areas of non-perfusion in the periphery. Dr.
So I
Tinku,
think
Dr. Sandhya?
one more point. I just want to discuss one more point. What I'm seeing is there's a difference in opinion from institute-based practitioner and a standalone private practitioners. So I'm telling like my view as a private practitioner because we have some limitations of Octa. The machine and the software we are given. So we have some limited number of Octas only as per now. Unless until we purchase for we pay them for more. So, this is also one thing. So, this is probably one reason that our Octa is more or less limited to CNVMs or wet AMDs and all. Whereas other conditions, all diabetic retinopathies and vascular occlusions, I do an FFA, a dye-based angiography always, at least a baseline one. So, then we can maybe follow up with OCT or Octa as and when needed. But Octas is more for AMDs and CNVM. CSR, a basic CSR, probably we won't do a fluorescein angiography in the first go, but the non-resolving CSR or where we feel there are multiple PDs, yes, that probably will do an angiogram. So this is a difference of opinion from as a practitioner, private practitioner point of view.
Mhm. Also, yeah, I feel that whoever is operating the Octa needs to be very well trained. Most of the time it's some new optometrist who comes, and so they make a lot of errors. The artifacts, they're not able to get rid of them. So you have to point out to them the specific area of interest, and I mean they should be very well trained. Either you're doing it yourself or you're trained your optometrist extremely well. Only then you can get the right information. And for me, yes, in diabetics, I would do a dye based at the baseline, or maybe even if I want to look for any leaking new vessels. At the end of my treatment, when I've already done the laser, then I would do an angiography. If I have to do a focal laser, then I would do an angiography. For AMD PCV, yes, Octa is the way to go. It's very rarely that you would need to do a dye-based investigation. And yeah, those are that's my take on it. So,
Thank you so much. I think we've had a very fruitful discussion. Dr. Sugneshwari, would you like to conclude?
Yeah. I think it was really a wonderful update, and a lot of learning has taken place, and people have, stayed back for so long into the dinner time here, and then we are eating on Octa now rather than eating our dinner. So I would like to thank Dr.
But we
Mohita
have
for
got a
the
very good feast. I mean, there were so many learning points, throughout the whole webinar. Thanks to
yeah.
Dr. Buna ma'am and Dr. Sugneshwari, you've taken so much of, efforts into it. And thanks, Dr. Anisha also and Dr. Karobi for, organizing the whole thing and, bringing us all together, and a very fruitful webinar.
Ma'am,
For
I
me,
have
it
a
was
question.
only a room away, so that was easy for me.
Ma'am,
All
I
the
have a
people were
question.
just in the next room. Yeah, Shivaranjani.
Ma'am, recently I had a couple of patients with the paracentral acute middle maculopathy. There, I did the octa. I couldn't find any other, means all the slabs were normal. So I would like to the expert opinion regarding these kind of patients, because occasionally we cross paracentral acute middle maculopathy patients for whom we just do the OCT and we go for the systemic investigations. Have anyone crossed about the octa findings in these patients?
I think it's more, can I answer that?
Yes, ma'am.
Yes, ma'am, please.
Yeah, I think paracentral acute middle maculopathy is more of an B scan based diagnosis,
Yes.
where in the acute phase you see the opacification of the retinal layers, and then later on you have the thinning of the involved layer. So you may not see too much on your B scan, especially in the acute phase, on your octa, especially in the acute phase. But sometimes in the deep capillary plexus, you may be able to see ischemia. So for
Okay.
PAM, I very rarely use an octa to diagnose. I usually use my B scan and maybe a multicolor. If you have a spectralis, the multicolor can also show it.
Yes, ma'am.
But I don't rely on octa for my diagnosing PAM or AMN.
Okay, ma'am. Thank you, ma'am.
So I think with that, we come to the conclusion of the retina update. The first session was. So I would like to thank our chairperson, Dr. Karubi madam and Dr. Sandhya for being here, and our master class, Dr. Muna Bende ma'am and Dr. Dhanishri ma'am for sharing her, giving her insight into the journey of her retina practice, and our esteemed panelists who are here, Dr. Tinku Bali, Dr. Parveen Sen ma'am, and our friends, Dr. Isha Agarwal, Dr. Rajshri Hirawat, and Dr. Sampurna, and our speakers who have taken so much of effort to, put all the slides together. And I'm sure they are, there are so many presentations which they have made, so many cases. It's indeed a task which they've all taken. So I thank Dr. Sivaranjani, Dr. Sneha, and Dr. Meenal Sharma and Dr. Preeti, in spite of all the odds, to have joined here. I thank everybody, and I thank Dr. Mohita for giving us the opportunity to be together today and, have a nice talk about octa. So I thank you one and all, and we will wait for the next session where we can have even more insights about another condition. So thank you, everybody.
Wonderfully
good night.
conducted, Sugneshwari. We have to thank you also for conducting it so well.
So
And
now that
it's such a pleasure to hear you that I don't mind listening to you for another hour.
she confused me. She confused me. She told me something, then I heard about the other speakers. So
Okay.
yeah.
But it was lovely listening to you.
Yeah, thanks.
And thank you, Anisha Mohita, for giving us this podium for sort of sharing our ideas. And all the speakers were fantastic. And my co-chairman, Sandhya, and the other panelists were also fab. So thank you. And let's say goodbye because I have to go back to my patients now. And
Oh my God. Patients are
I know
waiting for
Thank you
you.
so much,
I was
everyone.
breaking my head, with Sugneshwari. I said that what am I going to do? This is right in the middle of my OPD.
Wow.
Okay. Bye. Good
Good
night,
night.
everyone.
Yeah.
Bye bye.
Good night.
Good night.
Good night.
Thank
Good night,
you.
everyone. Thank
Good
you so
night.
much. Bye-bye.
Thank
Good
you.
night.
Bye.
Bye.